Hey everyone, it's Dr. Rick with a tutorial on bypass, but specifically bypass for people with diabetes. I mean, this corresponds to everybody that needs bypass, but specifically when it comes to diabetes, which is a more tangible disease process, more so than bypass, I think that it'll give you a point of reference. If I talk about bypass and you don't have any chest pain, don't have any history of heart disease in the family, you're not obese, you're not smoking, and I say, well, this is what you got to look out for. Well, you're not going to pay attention to it because you're going to think, I'm fine. But if I talk about diabetes and how diabetes can lead to that, then maybe it becomes a more tangible issue. So let's talk about this right now. But if this is the first time you're finding me, hit the subscribe button down below because I do videos all the time depending on topic of the week and topic of the day. And hopefully this will empower you. And please share this with other people because I was just in a hospital and one of my friends, relatives, went through bypass and he didn't even know he was going through this many jumps. And he thought that he was getting 1, maybe 2, 3, and he wound up with 4. And the number's not that important. What's important is to understand the disease process, recover, and make sure it doesn't happen again. But we'll get to that in a second. So if we start with diabetes, if you are a pre-diabetic or a full-blown diabetic, it doesn't matter, but this might correspond to you. And if you're not a diabetic yet, or the docs haven't found it yet because they're just looking with hemoglobin A1Cs every year, I'd be careful. I do fasting insulin levels, oral glucose tolerance test for 2 hours. I think that's more sensitive. Hemoglobin A1C, you're trying to get the horse in the stable and the barn door is already open. So that's why I think I had the discussion earlier today with patients that even pap smears and prostate exams, they're not suggested to be done every year, and I just don't know how you're going to find disease early enough and valid that if for the general population we're trying to save money and stop the screening process because it's not effective. Well, if it's not effective, what are we going to do with any kind of screening? We're going to wait until the last minute and then we'll come in and save the day. But how do we save the day? Massive surgery, massive medicines, hospitalizations, disability. And I think it still puts us behind the 8 ball. So here comes the lonely family practitioner that has a little bit of education in integrative medicine, and I think it can change the world, but it's not covered by insurance. So nutrition's not covered by insurance until you're full-blown diabetic, or you need bypass, and then it's covered. So anyway, hopefully this will empower you in the early stages when you're just a little bit overweight or having no exercise or eating poorly. So this is how diabetes works, and this is a blood vessel, my schematic of a blood vessel. This is what happens inside the blood vessel. Inside the blood vessel, you have the blood vessel transports blood, and in the blood you have these nutrients. It's like the highway. I referred to it with one of my friends as the fuel line for an engine, and the only way to get the gasoline from the gas tank to the engine is a very strong fuel line. Well, this is your fuel line. This is a blood vessel. This is your fuel. That's glucose. Glucose is a 6-carbon chain. Anyway, I did it as a little bit of a boat structure. Forget it. That's glucose. That's your fuel. Just remember that. And the glucose, which is the common fuel that we know about. I'm not going to talk about fat and keto, but this is the common fuel we know about. The fuel to get into the cell, the engine part that needs the energy, the fuel, it needs to have insulin. This is a little insulin structure. You can see it matches up perfectly with the glucose. It's a lock and key. So if the insulin and glucose come together, they can get through into the door of the cell, and the cell can utilize it as energy. The cell will take it into its mitochondria, that's the powerhouse, produce ATP, and you have a lot of energy. You'll also have a lot of byproducts of energy. It's called reactive oxygen species, but usually we can deal with that in time. So the insulin too, that allows this to get into the cell from the bloodstream, comes from the pancreas. This is the pancreas here. These are the beta cells of the pancreas. The pancreas is an organ that sits right behind the stomach or in your solar plexus. It's a little organ that secretes. It does a lot of things aside from that, digestive enzymes, but specifically beta cells secrete insulin. Alpha cells secrete glucagon. That's a different story. So if the beta cells are working properly, the pancreas is working properly, it'll make enough insulin. And if it makes insulin, it'll match up any glucose. a structure that's in the bloodstream and get you to the cell. I think we've established that already. The problem is if we have gobs and gobs and gobs of glucose, like overeating, or a little bit of a propensity to not be able to make insulin. Well, what happens is, I just stick with the first scenario. If you have way too many glucose fuel packets, or if the fuel packets come in at huge spikes because of refined grain, highly processed carbohydrates, sugar. If you have too much all at once, well, the pancreas can do what it has to do, but it has to push a lot of insulin quick. And sometimes it can answer the call for duty, but if it keeps on being stressed out by repetitive food choices like that, the pancreas will try its best to keep up with the insulin to match the glucose surge, but eventually pancreas is going to say, I can't keep up, and it's not going to make insulin anymore. It's a very complicated feedback process. I'll just keep it at that. It won't make enough insulin. Or because of just massive amounts of insulin coming in spikes, the cell will try to shade or protect itself from so much glucose and insulin by closing the door. I don't have it, but I'll X that. It'll close the door. So no matter if these two guys are in the bloodstream and they match up, the cell won't be able to take it because it closes the door. It's trying to shield itself from so much of the osmolarity. So much concentration, even if it's good fuel, if there's too much fuel going in, the cell will shut down. Just like an engine, an old-fashioned engine, if you had way too much fuel coming in, no oxygen in there, you would flood the carbohydrate, the carburetor. You'd flood the carbohydrator. You'd flood the carbohydrate. That's the thing that partitions the fuel and mixes it with oxygen, and then you can combust something in your cylinder, and then your engine shuts down. So the same thing happens here. The cell protects itself from this overwhelming amount, and it shades and becomes insulin resistant. No matter how much insulin, it becomes insulin resistant. It stops responding. And what does it do to the brain? It tells the brain, hey, there's no fuel around, when you know there's a ton of fuel. It's just that the cell had to protect itself, and it stops responding to the amount. And then the brain says a message to the pancreas, hey, make more insulin because there's no fuel. Eat more. Make the body go hunt for more glucose. That's what the preferential fuel source is. So the brain tells you, crave glucose, crave sugar, crave something fast. Then you have abnormal cravings, which sets you up for a higher spike of glucose. And if you eat a higher spike of glucose because you had bad choices, you couldn't think properly, you didn't say, I want to have a whole food plant-based diet, I just want to have something fast like popcorn, then you eat that stuff, it gets into your bloodstream, and then again you spike, and the pancreas says, oh, I got to keep up again, so it makes more insulin. Then you go through this terrible cascade of events. So that is a nutshell of what happens. Cell blocks itself and becomes insulin resistant. Pancreas stops making insulin, and then you wind up becoming a diabetic. So what happens with that? If the pancreas shuts down, you have to inject yourself with insulin, and you become your pancreas by injecting yourself with insulin every time you eat. Or you take medicines that will open the door again and become insulin sensitive. But eventually, if you get the medicines, get the insulin, and you balance out things, and you eat right and exercise, you should be able to reverse the disease process. First, you halt the worsening disease process, and then you slowly reverse. It takes a lot of work, but you can do it. If you just take the medicines and you don't make any lifestyle changes, don't stop smoking, don't exercise, don't control your nutrition, eventually this will fail. You'll be on an insulin pump, and if that happens, usually if you don't change your ways, you will get to the point where this blood vessel clogs up. And that's where we're going to talk about this. So hopefully that's easily understood. If it's not, then I'll probably be able to do it. I'm going to do a couple of more videos. So this is what happens with the time effect of a blood vessel. So a blood vessel, just like I showed you on my illustration here, that's a blood vessel with dots of red blood cells. And what happens is the dots of red blood cells, well, after a while, the lumen or the lining of this blood vessel, it doesn't need insulin to, it's really cool. Here's the lining magnified. These cells, the endothelial lining, they're one cell thick. They don't need insulin to get the glucose into their cells. So what happens is if you have a boatload, I know I'm at that boat structure, but if you have a ton of glucose inside the lumen of the blood vessel, it crosses into the lining of the endothelium, and it causes, when it gets into the cell of the lining, it causes an energy spike because the cell doesn't know what to do with it. It just says, oh, we got a lot of glucose, so I guess we have to make more energy, more ATP. So it sends all of the energy to the mitochondria. The mitochondria makes ATP, which you would say is good, right? But every time you make ATP, there's always going to be a byproduct of reactive oxygen species. And again, we can usually neutralize that in our cells with antioxidants, and the body has its own, or if you take your own antioxidants, cool. But sometimes if you have an overwhelming amount of that, you have way too much reactive oxygen species, and what does that do? That causes inflammation. If you can see here, reactive oxygen species causes a spike in phosphokinase, and it causes a spike in NF-kappa B, and that leads to inflammation. The inflammation in this one single cell, which is what this is supposed to be, turns on inside the cell, and the cell calls in, this is supposed to be a police guy, it's supposed to be a monocyte. So the monocyte comes and says, hey, we got inflammation. There's something going on in all the linings of all of our blood vessels, so let's attack. So it's supposed to, those little police guys, the monocytes, are supposed to just stop inflammation or take care of cuts and repairs in the lining, like with hypertension. But if it, across all the vascular bed, if these monocytes get turned on because there's inflammation inside these endothelial cells, then it causes inflammation inside the cell. It's called a foam cell. And it attracts LDL particles because you're trying to repair the lining of the cell. And what happens here is you have a little bump, a swelling inside the lining. Think of it as an internal pimple, like a pimple in your eye. You can see the bump, you can feel the bump when you close your eye, you can feel the bump on the eyeball, and it hurts until you pop that thing, and then everything is cool, or it decreases in swelling. Well, the problem with the lining of the blood vessel, it doesn't pop. It just continues. If you continue on your bad habit, it continues to accumulate more and more damage, and that's called atherosclerosis. More police guys, monocytes, get attracted to this inflammation cell, and essentially it's not just one cell, it's all the cells lining every blood vessel of the body. A heart, arteries, kidneys, blood vessels, fingers, eyes, kidney, well, that's what happens. Usually if you're a diabetic, you'll have problems with your eyes. You'll have problems with your kidneys. You'll have problems with your heart. You'll have problems with the nerve endings and the blood vessels of the fingers. So all that happens because they're the most important structures that get affected first. So you'll have accumulation of damage. You'll have the damage. And when damage occurs, you'll have more police come in and cause more damage. This is an organized clot already. And you can see it's taking up more than 50% of this lumen. So you essentially narrow this blood vessel that was wide open and patent to feed blood and red blood cells and oxygen to every major organ, including the heart and the heart muscle. It's narrowed. When it gets narrowed, not that much blood. It's like turning the faucet down, like watering your flowers, but yet turning the hose to almost trickle. You're not going to be able to get the water out, and you're losing fuel to the flowers. Well, here you're losing fuel to the muscle, which is the heart muscle. And when you have the fuel, at least the blood clot big enough, you'll actually have little clumps of these white red blood cells inside that cause a blood clot, and that leads to a sudden narrowing. So this is a squash, but I did it because the squash has some veins in it. I don't know if you can see that, but these are all veiny. Anyway, that is one specific vein. Say that this is a representative of your heart, and with this heart you have a blood vessel that goes from here to here. Well, I've already indicated the narrowing right here. And if this part is narrowed, and it's supposed to go from your aorta to wherever it goes to feed oxygen, when this continues to pump and do its thing as far as a muscle, if it doesn't deliver the oxygen in the blood flow, if you pump a little bit too much, the heart's going to say, whoa, I can't get past the narrowing, and it's going to freeze up the muscle. The muscle's going to cramp. Kind of like you running for the first time. If you're training for a 5K, your muscles cramp up. Imagine your heart cramping up. So what happens is when the doctor sees the narrowing after getting a cardiac cath or a stress test, and seeing exactly where one or two of the narrowing, those narrowed parts are, they'll plan to do a bypass. All a bypass is that they'll take a vein. This is supposed to be a vein. Take a vein from either your legs or an artery from inside your chest, and they'll try to bypass the little bit of the narrowing. So they'll go from here to here. And so I effectively, and it's essentially just punching a hole in here and having, you sew this little blood vessel that they secured from another part of your body, and they bypass the little narrowing. So that's your bypass. Now, this usually stays pretty patent for up to 10 to 20 years if you take care of your disease process. Lower your cholesterol, lower your blood pressure, control your diabetes, all that stuff. Work on stress reduction, stop smoking, lose weight, exercise, all that will work, and this bypass will last up to 10 to 20 years in some of the studies at, I think, Mayo. So even if you're a diabetic, the chances of this clogging up, even if you're a diabetic, are the same as a non-diabetic. So these things last, but that's compared to an angioplasty. So an angioplasty, or just think of a stent. Sometimes you can, if you don't want to do this, and you want to avoid the open heart problem, well, if the guy is good enough, he'll send something through the groin into the aorta, and they'll put a wire in here, right inside the blood vessel, and they'll pop open the wire, and that'll keep it open, like a stent, like a support in a tunnel. In case the tunnel is collapsing, you'll put a steel mesh in the tunnel, and it'll keep the tunnel open. Well, that can open up this narrowing, but the problem is getting that there might be very difficult. So this is nice because it's a straight blood vessel, but a lot of blood vessels will go in right angles. So if the blood vessel is, number one, it's got too many narrowed spots, or number two, it's kinked. It's going to be hard, technically hard, for that doctor, that cardiologist, to put a stent in there. They're getting better than the 90s, and there also is inherent risk. Whenever you put anything into a blood vessel, you might pop out the other side of the blood vessel. So that's immediate bypass. That's why they always have to have a bypass team. Anytime they do a stent in the hospital, they always have to have a bypass team ready in case there's an accident. That's true. And before, if they were doing more than one stent, they would say, no, 3 stents and you have to go to bypass, you're better off. But now they can actually put a couple stents in. So there is a possibility of stenting, but what I've found, honestly, with most of my guys that went through a stent, single artery stent, well, the problem is, if you have one area of narrowing, you'll be lucky. But most people who have diabetes, elevated cholesterol, smoking, they will have a couple areas of narrowing from a couple different blood vessels. So what are you going to do? Can you put a stent into all these things? Technically, that would be about, an 8-hour surgery. So what they do is they'll get the most narrow, or the area of the heart that's suffering the most, and they'll say, if they find that the LAD, left anterior descending, is the worst, they'll try to stent this guy open. Pop it open and keep it open with steel mesh. And they'll let the other ones just sit there because they might not be to 99%. If it's 99%, you need to open that quick. So what I have seen in the majority of my patients with stenting is, if they don't change their behavior of eating, exercise, good sleep, stress reduction, stopping smoking, then usually the stent will stay open, but the area, say that was a stent, the area before and after the stent will continue to narrow, and then you'll fail the stent. So that's why I think in the long run, if you look at the statistics for stenting, usually if you don't change your ways, within 6 years, the stents will close, or you'll have narrowing at another place and need another stent. So in most cases, if the stent really doesn't make a difference, you will still end up with a heart attack eventually, unless you change your ways. And for somebody that's had major pain, a stent, and they went to the hospital with 10 out of 10 pain, and they went home with 0 pain, within 5 to 10 minutes, you get 5 to 10 minutes to go to the hospital, about 30 minutes to alert the team that you're having a non-ST segment elevation and a heart attack, and about 45 minutes before the entire team is in the surgical suite and you're in there, and you're awake when you have this done, Well, usually because of such a fast relief, most people don't change their ways, especially with one single stent. So I usually will see after about 6 to 12 months, the patient goes back to work because they have to work, or they go back to their eating pattern because, well, they're feeling better, until the point when they have to have bypass. So that's why if you need a stent, you need a stent. And it's a fairly routine procedure. Most hospitals can do it, and you're in and out of the hospital. But in fact, most of my guys that go through stenting, they don't get cardiac rehab, which I think is terrible, because cardiac rehab gets you to reverse your disease process. Cardiac rehab, learning how to exercise, learning how to eat. Well, a lot of guys just refuse to do that because they don't have any time. I should say guys and girls. Because they don't have any time and they feel good. Versus having the CABG, CABG is coronary artery bypass graft, and then having to, or being forced to go to, let me put my bypass back in order, being forced to go through rehab because you have no choice. After having your chest cracked open and wired back together, and blood vessels taken out of your leg, and a blood vessel stolen from your chest, you are debilitated, and you need bypass. In fact, it's very difficult to learn to walk again. So the guys that go through bypass, they feel the pain. So they are usually inspired because of their memory. I don't want to do that again. I think that's why most bypasses, patency is important, but most bypasses do better than angioplasties or angiostents. It's not an angiostent, it's a stent placements. So in the long run, bypass will save you. If you don't make a change, you will still have a problem, because remember, even if you have the heart taken care of, 80% of the time, if you have a narrowing to the heart, you'll have a narrowing to your neck, and your brain is the next thing that goes. So stroke is soon to follow. So most of the time, my bypass guys do great, but man, it's such an arduous process to get to learn to walk again, and then be forced to do rehab and nutrition and exercise and lifestyle modification. So I think they do better, but the threat of going through bypass is always visibly there, and it's mentally there, so they do okay. The guys that go through stenting, there wasn't really a threat. It was just, remember what you had to do? Go into the hospital and get into angioplasty? Well, I think there's a threat there, but the farther you get from that date, the more you'll forget what you did. Now, I'm not saying that with everybody. Sometimes a new lease on life for that one stent that was placed won't be enough. And maybe the threat of having possibly lost that person with the family will be enough for the family members to keep on pushing. But unfortunately, if you are to this point, then hopefully this gives you an idea about what happens with bypass grafting. And bypass is usually going to be quadruple because disease is so profuse. But it all starts with that preventable disease process of increased weight, increased glucose, increased cholesterol, and lifestyle change, or a little bit too high of a weight, too big of a waistline, too high of a blood pressure. And those are the things that we find in the office during your wellness exam. And that's why it's up to you to make the changes when your doctor defines this stuff. When it's discovered, it's not a point the finger thing at you. It's not like you are now in trouble and it's all on you. I work with my patients as a team member. I'm captain of the team, but you're just as important. So is the nutritionist that you might enlist. So are the books that you read. So is the exercise physiologist that helps you design stuff. So all of it starts in the beginning. So if you go to your wellness exam or insist on a wellness exam because insurance covers it, and yet during the wellness exam, after it, you don't want to make any changes because you don't feel bad, you're asking for trouble, because you'll eventually, not everybody, but eventually wind up here. But listen, if your wellness exams over the years keep on pointing to the same disease process and nothing's changing, it's time to call in the reinforcements and just do the medicines. Nobody likes medicines. Nobody likes bypass, but nobody likes medicines. And I know it's a pain and there's a ton of side effects, but it'll give you a short-term fix for what hopefully will be a long-term solution if you make the lifestyle change. If you make it early when everything is discovered, you're better off, because you don't have to go through the arduous process. And there's other trickle-down effects of healthy lifestyle: better sex, better sleep, more problem solving, easier clarity of mind. So there's a lot of things that are positive with that, but it all starts with the wellness exam. It all starts with also looking at your scale, knowing what you're eating, being truthful with yourself and saying, well, I probably should turn down that extra helping of food, or I probably should not have that sugar in my coffee, or I probably shouldn't have that ice cream. It's tough. I'm going to go work out now. I'm a little bit late, but I wanted to do this, and I keep it to a minimum, but I will not stop exercising because I know it helps me to do what I can to prevent the diseases that are coming my way. At 57, I have a ton of diseases coming my way, but I hopefully am doing my thing, but I expect my patients to do the same. And if you can't, then I will devise a team of people to help you, or we'll throw on the medicines. Either way, hopefully this gives you an idea about, I'll have other parts to this tutorial. Hopefully this gives you an idea about how something as easy as an elevated glucose level, whether it's prediabetes, maximized diabetes to the point of severe uncontrolled diabetes, or just early stuff, maybe just a little bit of a weight issue, how it sometimes leads to this. So it all starts with those first steps. And the biggest problem, Martin Luther King, you don't have to see the whole staircase, but you have to take the first step, you'll know you're in the right direction. So hopefully this gives you a little bit of a hand. If you have any questions or comments, put them down below. Otherwise, I'll see you at the next tutorial.